and a lateral. If it's well done because you can see the lesser trochanters, okay, either on a combined pelvis view or on your segmental examination of the hip. Okay? Now, when you look at this exam, lumbosacral junction, SI joints, hip joints, and symphysis pubis need to be part of your search pattern. Okay, and my favorite test example of a test case would be Pars defect that you can barely see or degenerative changes. In other words, multiple areas of involvement. You're so focused on what you see, you forget to complete your search pattern, and now there's another area of involvement. So two disease processes or abnormalities in the same patient. Okay. All right. So it's either pelvis. Where does the central ray go for this? Greater trochanter. Okay. Now it shouldn't make that much of a difference. You want to put the light here, but I think the reference point is greater trochanter is so much easier. All right. Believe it or not, some people do take good X-rays, so well done. This is an example.
Oh my God.
Well, you've sat with me enough to know, seen all the
Trash.
being kind.
Yes, sir.
Okay. So what we're focusing on is the hip joints, okay, to whatever degree you want to enter into that, all right? At this stage, we're just saying this is still femoral head, a full bladder, coronal perspective. We'll expand on it, okay? All right, so now, we're going to spend a whole lot of time talking about this. If we didn't, it's a good review. If we didn't, we are now talking about it. If we did, it's a good review because there are certain lines that apply to the hip joint. So here's my positioning. Now we want the feet parallel, toes in like we always have, okay? And I just continue that on for the whole lower extremity. Because when we do an ankle x-ray, we do this, little bit of internal rotation and toes up. So just connect the dots. We're gonna do that same thing for hip, knees, ankles, and feet, okay? So I want that position. I want a gonadal shield for your patient, and then I aim at greater trochanter, halfway between symphysis pubis and the lateral margin of the leg, and that generally ends up being right down the quad for the AP view, okay? Now the challenge is the gonadal shield may have to be moved ever so slightly so that you're not covering up, and you want to probably use the smallest
Bless you.
gonadal shield because the big one is going to cover up too much real estate. Okay. Next one is lateral. Well, it depends on what your patient can do. So, okay, can they do this? Figure 4, same central ray, okay, to the halfway between the symphysis pubis and the greater trochanter. Can they do this? Okay. Or can they put their leg on a chair, on a stool, and you're entering the same spot? Okay, so it depends on what your little old lady can or cannot do. I can guarantee you she's not going to be able to climb up on your table for a recumbent exam. Okay? Now, it doesn't have to be a chair, that little low stool will work, okay? It's just easier for them. And if they're already unsteady, whatever you want them to hold on to, okay? That makes sense? Positioning is the easiest part always. All right, so now we're going to be talking about all of these, okay? So this dimension is a normal hip exam, so let's do the lines first, the colored lines. So this is the iliopubic line, all right? And it's the stronger component of the hemipelvis, if you want. All right, this ilioischial line, the purple at the bottom of it, there's a U-shaped structure that's referred to as the pelvic teardrop. So if this femoral head is, the knee is up against the dashboard and you come to a sudden stop, this femoral head is driven through the bony pelvis and sits in the anatomic pelvis. Now that's not good, why?
That's your
Visceral structures and
Visceral structures, okay? Whatever you want, okay, bladder, neurovascular bundle, okay? So the idea is it will first disrupt the ilioischial line, and it's very, very small. When you take a look at a pelvis, I should bring my pelvis back in. you can almost see through it, this area called the quadrilateral plate of the ilioischial portion of the ilium, and it just blasts through there, breaks it, comminutes it, and the next thing you know, the femoral head is in the anatomic pelvis. Okay? So keep in mind or understand that this is the stronger of the two. We always look at this. This is our acetabulum, and the acetabulum has this normal white band or radiodensity. That's normal. Okay, because the labrum is cup-shaped, so you're looking at my hand from your perspective. All right, that's normal. The dimensions, when you're looking at it, 4 millimeters this way, 4 millimeters down here, and in the region of the fovea, notice the space is bigger. 8 millimeters is what we would like to evaluate. The diagram is well done, okay, because I see lesser trochanter. There's lesser trochanter, but this is just a real AP hip examination. Okay. Symphysis pubis, there's age and sex variations between males and females, but for the most part, no, not more than 5 millimeters, wherever you want to measure it, is a good starting point. Okay. Now, how does the symphysis pubis become involved with disease processes?
Legs up, pregnancy in a car accident.
Legs up in a car accident, I can see where that might happen. The pelvis is a ring structure, so if you affect one part of the ring, the other part can be affected.
Pregnancy.
Pregnancy, hormonal loosening of the ligaments, yes, good. Okay. UTIs, chronic UTIs can affect the symphysis pubis, okay?
Weakened pelvic floor.
Well, that's soft tissue, right?
Oh.
Okay. Remember, symphysis pubis is fibrocartilage, not diarthrodial joint, okay? And I'm sure you've had the same experience as I, okay? You were riding the bike and your pedals, your feet slipped off the pedals, and the next thing you know, you were going down, and it hurts just to talk about it.
Yes.
Trampoline trauma, okay? So we forget. So when I'm evaluating the hip joints, I want to go around and take a good look at symphysis pubis. All right, so the idea in the pelvis, because it is a ring structure, those 6 or 7 anatomic areas become important. Now, when you look at it, this transverse dimension of the obturator foramen is wider than this. It's just a good example of that. You can get a greater discrepancy, and I don't know what to make of it. It's a visual observation. I don't know what the Gonstead people or the Thompson people would say. Is it a pelvic distortion, rotated some way, okay? I don't know. I'm just saying I've made the observation. What you do with it, if you weren't one of those practitioners, you wouldn't even care. Okay? But when the patient says it's always the same side at SI joint that this dimension is reduced, then all of a sudden I'm thinking, okay, is there a causal relationship? What's going on with this? All right. Okay, lines. 2 lines. This is the normal. So when you draw a line along the inferior aspect of the superior pubic ramus and bring it over to the medial cortex of the femur, it's supposed to be a nice C-shaped curve. Here it's interrupted because the femoral head is been superiorly and laterally displaced. Okay? Now that could be positioning because you didn't have the pigeon-toed thing, or it could be because of severe trauma. And that's just one of the lines that we use to evaluate, is the femoral head sitting normally in the acetabular cavity. The next line we commonly or most often draw is iliofemoral line. The line that comes down here should form a nice smooth C-shaped convexity as well. The more of the lateral femoral head is lateral to that line, is that your first indication that something is abnormal. You've heard of split capitofemoral epiphysis?
No.
Yes, may have, may not, okay. So it affects the femoral head, all right, where the epiphysis of that femoral of that femur becomes abnormal and is dislocated, all right. And one of the signs there is an abnormal iliofemoral line. So why am I bringing up split capitofemoral epiphysis? It's a common injury in the adolescents, the skeletally immature. So it's an example of where the iliofemoral line would be disrupted. SCFE it comes up again in trauma, but it may also be a word picture in Part 2 national boards. Which line is evaluated which line is considered in the evaluation of a slip capital femoral epiphysis. It's either Klein's line, okay, and we'll talk about that shortly, or this thing called iliofemoral line. Coxa valga, so what I just usually teach is the more it proceeds a 90-degree angle here, okay, it's coxa if that angle opens up, it's coxa valga. It's that simple, okay? Now, I don't think I've done this more than once or twice, because it's a big visual observation, okay? By the national boards, they want you to know the femoral neck shaft angle. They want you to know this angle as well, okay? I don't know if I have a picture. Yes, I do. Okay, this angle, and that's referred to as Skinner's angle, okay? Put it in the appropriate box. It's National Board Trivial Pursuit. If you see a Skinner's angle on National Board, they'll be the most shocked person around. Okay.
Oh,
But this image also points out, this is a normal capsular line here. This is a normal capsular line, so it could be straight or bowed medially this way. That's normal, or two variations of normal. When it's bowed laterally, same principle as the elbow. This is the little person that comes in limping. Their hip joint is filled with synovial or inflammatory fluid, and that's why they're limping. All right? And if you intersect with the x-ray at the right time, you will see capsular distension. So we use this relationship all the time, but it doesn't take, if you see the lesser trochanter, you've got a normal anatomic alignment between the head, the femoral, the neck, and the shaft. If you have to measure it, you're going to do this, okay? And that process is Skinner's line. Now, next thing in terms of detection, this is 1, 2, 3, 4, 5, 6 anatomic areas, but also you will see abnormalities. So if your pelvis or lumbar spine x-ray is cut off here, let's say, okay, this is a common area where there's disease. Why? Because it's metaphyseal region, and metaphyseal is a high biologic activity area, and on your lumbar spine x-ray, if you're not completing your search pattern, you're going to miss something here, and that's called the four corners principle, meaning if there was a big lesion sitting right here, we would probably all see it because it's midline, but disease processes don't understand that. They like to hide in the corners of the film, either proximally or distally, so I'm just explaining it in a different way, okay? And you'll see enough examples of what I mean so that you get the point. Okay, so a few minutes ago we talked about slip capital femoral epiphysis. This is how you detect that. So the normal relationship is when you draw a line along the femoral neck, the lateral aspect of the femoral neck, there's a little bit of a D-shaped radiodensity adjacent to it. Everybody see it where the laser pointer is? Okay. Now, everybody's going to have a little more, a little bit less, depending on their age and sex. The idea is when there is nothing lateral to that line, that's the abnormal side. And that line, or rad line, or rentgenometric, is used in detection of slipped capital femoral epiphysis. We don't want to write that so many times, so we just abbreviate it SCFE. Okay. Now, I could have also gotten to it if I did my iliofemoral line on the abnormal side. I'm going to get to this point and say, why is there no D-shaped radiodensity to the lateral side? So it's application of the iliofemoral line and the abnormal Klein's line. All right. Now, child or adult? Child. Okay, I look at it and I say, okay, a relatively normal relationship. Okay, we don't get into his mild mild coxa valga. If I had to measure it, I'd have to do the same thing as we just showed you. Okay, this thing. But I'm not going to spend that time because, yeah, it's a little bit off. Okay, there's no absolutes. And you've heard me say before, we're trying to attach a one-dimensional line to a three-dimensional human object or human. All right. For me, I'd put a star beside that. Don't care about that. This is a given for both me and for national boards. Okay, now we get into the normal variants. So os acetabuli, you know where it is. It's an accessory little ossicle. All right, just like that. They can be unilateral bilateral, small, medium, or large. And if I have one, doesn't mean I have one on the opposite side. It simply means that when this osseous ileum and the pubic rami were fusing together, a little group of cells decided they didn't want to join the party, okay? And they become ossicles. They're not pain generators, they're just a normal variant, okay? And on this side, we can see a little bit of our capsular line at least, okay? And it looks the same, so this is an example of a larger acetabuli, okay? Coronal, axial, or sagittal on this cut. Coronal, fat suppressed image, just, okay? Now, when they get this large, okay, if the patient has hip pain, they're gonna look at it and say, from an arthroscopic perspective, and say, does it have to come out? This one, the small one on the left, your left, leave it alone. The bigger, the greater is the likelihood that it's causing some kind of impingement or some kind of an issue. Okay, does that make sense?
Mhm.
Okay. Femoral acetabular impingement. Okay, we think the hip is just osseous, but there's a labral component, and with repetitive hyperabduction. So who does repetitive hyperabduction? Gymnasts, okay, or on the bar, whatever this is, that activity, okay, and that causes this acetabular ossific density related to the acetabulum, and that is one of the types or one of the conditions that falls into the group of this femoral acetabular insufficiency or impingement. Unilateral or bi, it just depends on what you x-ray, okay? So in this case, there's abnormal, this is where the yellow arrow is abnormal. There's also something abnormal here, a normal variant, and another one on this side. And look at the difference in discrepancy between this obturator frame and this one. I see that so often, I just wonder what it means. I'd be curious to see what how the patient presents clinically. Not normal, depending on the activity, okay? Pits, herniation pits, fibrous conversion defect are the synonyms. Again, small, medium, and large. This one is a ring-enhanced radiolucency is one way to describe it, all right? On the MRI, it attracts because it's filled with fibrous tissue. Bright data or signal intensity on the T1 or T2 weighted image. This is still fovea. This is still lesser trochanter. All right. So plain film, two different patients, but for purposes of what I want to describe for the national boards, plain film. All right. The advanced imaging and what kinds of decisions can you make? Small, medium, or large, unilateral or bi. I have also seen them as a little cluster of 3 or 4 of these, much smaller in the central portion of the femoral neck or on the medial side. Now you would think, this being as close as it is to the cortex, it should undergo pathologic fracture, but it doesn't, okay, for whatever reason. It's more likely that the little old lady or the little old man steps off the curb, sharp pain, yes, they fracture because they have lost bone density. These fibrous conversion defects are generally inert, okay, not a big deal. But what this does show is that's what a normal capsular line should look like, all right? And I think I was on the previous image. Nice pelvic teardrop. So the laser pointing goes down, comes back up. That's the teardrop, and then this is the ilioischial line. This is the iliopubic line. So the weakest point is a certain portion in this ilioischial line that is paper thin. It's like your scapula. That's why when you get a blow to the back of the traps, you can fracture not the spine of the scapula, but the weaker, more porous scapular body. Okay, depending on how you get hit. In kids, or skeletally mature, all right, the secondary ossification center starts in the region of the anterior circumiliac spine region, okay, and it works its way towards the SI joint. That's its normal course, okay? And it should be developing at the same time, so the diagram. So when I see this, I know roughly Each one of these corresponds to an age. I can't tell you which point it is, but they're somewhere between 15 and 18 years of age. All right? Now, where the laser pointer is between the secondary center and the ilium, it's not empty space, it's filled with fibrous tissue. And depending on the activity, you can cause axial stresses, all right? So if you're continually tractioning, or it's continually being tractioned like this, superiorly, this can become symptomatic. I remember a case, he happened to be a serious cyclist, okay? And until he stopped this is trying to fuse to this. It's not being allowed to do that because of the axial stresses, okay? Sports activity done to excess will stress your skeleton abnormally, sooner or later. Okay? So my suggestion is you can start yoga anytime. You coming? Yeah. Love yoga. Hot? Love yoga.
Hot and cold.
Okay, in the pelvis. I didn't hear it, so. Okay. You get these little calcifications as we get older, everything sags, so calcifications within pelvic veins. They usually follow the anatomic rim, okay, small, medium, and large. You look at it and say this patient must have a tumor of the soft tissues. No, they're just varicose veins in the anatomic pelvic veins, and these happen to get infiltrated with calcium, and that's why they look the way they do. Okay. Normal variant, in other words, you see it in elderly patients a lot, okay, and it doesn't satisfy the criteria. It's a comorbidity or disease process. It's just one of those age-related changes. This is the name. If I don't know what the other person on the other end knows, I'll put fibrillous calcification in pelvic veins until we've had some interactions and I get a sense of what they're doing. DDH, developmental dysplasia of the hip. So the skeletally immature individual. So now, if I did my normal iliofemoral line, everything, the femoral epiphysis is medial to that line. On the opposite side, there is failure of that normal relationship. Now, understand, this is subtle, or can be very, very subtle, and that's why there is such thing as pediatric radiologists who stage the age of the individual. Is that skull growing at the normal rate that it should be? Okay, and there's all kinds of lines that can be drawn. All right, I'm not asking about that. I'm asking you to understand there's a developmental dysplasia of the hip, and when the hip starts to develop, okay, it's the femoral head inside the acetabular cavity doing this that causes this to become deeper and deeper. That's why it's such a stable joint. If that doesn't happen, I have a shallow acetabulum, and I still have a femoral head, and then that femoral head can just slide. Okay, and that's developmental dysplasia of the hip. Does that make sense?
Mm-hmm.
Okay. And I'm all about application, so my sister, okay, we didn't know, we had no reason to x-ray her. Okay, I saw her in April of a couple years back in Phoenix. I was lecturing there and they came down to visit. She said, it's killing me, it's like glass in there. And I wasn't thinking very clearly. She had x-rays done. She had developmental dysplasia of the hip. So I saw her in April. By July, she had hip surgery. Okay, and you'll see the MRIs, the plain film and the MRIs. On the MRIs, the whole labrum portion of the hip joint, it was described as macerated. What does macerated mean? Chewed up. Totally chewed up. Okay, so we had no reason to x-ray her when I'm looking back on it, but what did I know when I'm 3 years older than she is, so there was no reason. She had no pain. She played high school basketball, she was an athlete, she liked running and all those things, and now it just flared up, okay? So the idea is between this and at age 65 roughly, that's how long this can take to manifest itself. She's doing very well. I'm gonna see her this weekend. Her son's getting married, one of her sons getting married, and I'll ask her about her hip. She has a big scar, okay? Our accountant's wife, she had the same procedure. She has a much smaller scar, so it really depends on who you are using, how they were trained. Some like to be minimally invasive, others just open up the hip joint because it takes less time, put in the hardware, and then get back out as quickly as they can. All right, so developmental dysplasia of the hip. The teaching point is diagnostic ultrasound is how this gets picked up, okay? Now, if the small town that you end up practicing, it doesn't have a CT scanner or a MRI center or a center that has one of those, they will usually have an ultrasound unit at the hospital. Why? For female pelvic issues. So uterine fibroids, birthing issues, you can always get an ultrasound, okay? And the ultrasound can be used to detect, that's the first entry point, all right? By the time you see them at age 6 or 7, you can do a plain film, but the femoral head and the hip joint has already has had a certain amount of development. So those stages, when we go from crawling, okay, to upright, is when I as a chiropractor want to see them, because they don't get upright and start walking. They cling to the desk or the chair, they fall on their butt, okay? And as far as I'm concerned, that causes problems with their SI joint. I want nice sacroiliac joint motion, okay? And if I have to take an x-ray, I should be able to see if there's abnormal relationship, okay? Now, this is how it gets detected early on. The nurse who's in that small town hospital has seen 30 to 300 cases of this. They do inward rolling of the hip, external rolling of the hip. If that's not normal to her sort of satisfaction, this is the test that they order, okay? They only do MRI or anything advanced if they're thinking about surgical intervention, okay? So this is the entry point. So you can add one more thing to diagnostic ultrasound. Gallstones, nephrolithiasis, uterine fibroids in the female, okay? And now, if you're worried about in the little person and you thought there might be effects of, if you didn't see anything on your plain film, you can ask for diagnostic ultrasound to evaluate the possibility of delayed developmental dysplasia of the hip. It's a nice exam, not that expensive, just a question of whether there's availability wherever you are, okay? Don't need that. They forced me to stand in the middle, why? Okay? So what did we learn? We learned the lines, the colorized version, okay? Notice I didn't talk about this or this, that's not germane to your needs, okay? These are just talking about the sacral ala. So the sacral ala are holes where the lumbosacral plexus exits, okay? And it makes sense that if a patient that you have falls on their bottom, they could fracture these sacral foramina. You're not gonna see it, why? Because you didn't think it was important to evacuate the bowel, okay? And now it's filled with gas and fecal material, and there's no way I can see a small sacral fracture, okay? But I can see, I've got 2 cases to show you where the elderly patient fell on their bottom, and the anterior cortex of the sacrum is fine until there's a little indent, okay? Not foramina, but the body of the sacrum can fracture. The other thing you can hurt when you fall on your bottom is the back end. What's the back end? Coccyx. Okay? I forget, it's getting mixed up, but we saw sacrococcygeal dislocation is about 2 weeks ago. I'm trying to remember who was in reading with reading with me, but we saw it, okay? So it's more than just lumbar spine, it's sacrum/coccygeal region, all right? And you know my argument, if you've had back pain for 4 to 6 weeks, get the previous x-rays. If they're great, you can use them. If they're shitty, pardon the pun, you make sure you evacuate the bowel, okay?
Hey,
What do you get? Go home, it's 2 o'clock in the afternoon. And I'll argue until the day you graduate, there's enough time. You just have to organize how your patient's going to go through your routine. They're doing all the work, they're doing it ahead of time before they come in, and you have the satisfaction of knowing I've got a good x-ray and I can make better clinical decisions because I see what I'm supposed to see. Okay? What else? What's wrong?
The bras on. The femoral head on the right side is coming through.
Okay.
That's a tabby.
So if this is the normal side, this is the normal presentation. So where I was trying to explain to you, the femoral head has been driven in and it's destroyed, not the stronger line, but the smaller line, the ilioischial line, and this is referred to as protrusio. It's protruding into the acetabulum, okay? Must have been a severe blow to allow that to happen, okay? Now, it's not affecting bladder, all right, but you would think this patient would have gait abnormalities,
Oh,
right?
yeah.
That's just a close-up of it. So this line is intact, even though it's covered by the displacement, the protrusio, but the ilioischial line is the culprit. It can't take that blow, okay? So it's this, the dashboard, okay, and that pushes, and it goes the path of least resistance, which is laterally, or if it goes the other direction, it's going into the anatomic pelvis, okay? It slays me every time I'm driving down and somebody's got their bare feet up against the window. That's a good shearing, right? Don't even want to think about that. All right, so protrusio acetabuli from a chiropractor, I think, in North Carolina. Okay? So that was the short version of the hip.
Thank you.
Okay? So what we can do on Monday, no, we don't have time because we're doing written and practical. That's the next thing, the position. So once we get to the foot, there's the next positioning practical for your edification.
Now, are the images on Monday just related to the shoulder?
No, upper extremity. Okay, now you mentioned I'll make sure, but I'm pretty sure I put all the normal variants in PDF, but I haven't given you any cases. We can still do that for the
There is a
Instagram.
project too.
Pardon me?
There is a project too
Yeah.
next week.
There's project 2 coming, but I only have,
Do you need to update that so don't look at it?
yeah, you don't, no, you're not looking at projects until I tell you I want you to look at projects.
Okay, I don't know, I just wasn't here last week, so.